Next we have Dr. Madhu George. She is going to speak about mechanical ventilation in a neonate.
Good evening, ladies and gentlemen. At the outset, thank you to the Department of Anesthesia for this opportunity. My job is to speak on the mechanics of neonatal ventilation. I intend to do it by giving a few case scenarios. I don't think I need to talk on the theory of ventilation to an audience comprising anesthesiologists, and I'll try to keep it as simple as possible. The only challenge was how to make it sound like a cat and mouse game, as the organizers have labeled this presentation. So let's see how it goes. Just a few words on normal newborn lung physiology. A normal newborn breathes at a rate of 30 to 60 per minute. It will be in the range of 30 to 40 per minute for a term baby. Preterm babies breathe at a slightly higher rate at about 50 to 60 per minute. The normal tidal volume for neonates is between 4 to 6 ml per kilo. For extreme preterms, it will be slightly higher at 5 to 6 ml per kilo, and for a baby more than 2 weeks as well. Roughly speaking, we can put it as a range 4 to 6 ml per kilo for any newborn baby. Now, there are a lot of modes of ventilation, but then the ones which we use commonly in neonatology are synchronized intermittent mandatory ventilation and assist control ventilation, or SIPPV. Now, in synchronized intermittent mandatory ventilation, we give a preset number of breaths. Whatever preset number of breaths are given, they have got a pip and a peep, but then the baby could very well breathe in extra, and whatever breaths the baby takes in extra, they will be unsupported. On the other hand, very simply to put it, in assist control ventilation, whatever spontaneous breaths the baby takes, that will also be supported by the ventilator. And because that happens, the tidal volume which is being delivered every time the baby breathes would be more friendly and more uniform. So this is what happens in intermittent mandatory ventilation. The color in purple signifies the spontaneous breaths the baby is taking. It could very well happen in an asynchronous fashion, so that those breaths are unsupported, and sometimes the baby would be taking breaths when the ventilator is also delivering its own breaths, causing the baby to fight the ventilator. Now in SIMV, we find that if a baby breathes at the same time the ventilator is delivering the breath, that will be synchronized, but still there would be a few odd breaths in between where that doesn't happen. And the lowest graph will show that the tidal volume which is being delivered when the baby takes a spontaneous breath is not very high. In SIPPV, that problem is mitigated to a greater extent, and you can see in the tidal volume being delivered that it is fairly more uniform. That is because each and every breath that happens is supported by the ventilator. And these three graphs also show the erratic pattern of flow that happens in intermittent mandatory ventilation. That chaotic pattern is mitigated to a small extent in SIMV, but then it is solved to a greater extent in SIPPV, which is why SIPPV ventilation has got a lot more benefits in newborn. Now we come to our first case. We have a 26-weeker preterm baby boy who had a birth weight of 620 grams. Now he's more than 2 months old with a corrected gestation of 35 weeks plus, and he weighs 1.6 kilos. He had needed prolonged ventilator support, but presently is breathing in room air. He is found to have a reducible right-sided inguinal hernia. We call our surgeon, he reviews the baby, and the baby is booked for an elective hernia repair the next day. Prior to surgery, he is reviewed by the anesthesia team. The baby has pre-anesthetic blood works done. We arrange for blood products in case he needs it, and he's posted for surgery the next morning. He's kept NPO from 2 a.m. in the morning. He has a peripheral IV access secured. He's also on maintenance IV fluids at about 130 ml per kilo per day. And at about 8:30, he's ready to be intubated prior to shifting to the OT. He's pre-medicated prior to intubation. We give him an anticholinergic, a sedative, and a paralysing agent. They are atropine, fentanyl, and rocuronium. He is intubated with a size 3 ET tube and fixed at 7.5 centimeters at the lips. We confirm equal air entry bilaterally. There is misting of the ET tube, all of which tells us that the intubation is proper. His heart rate is fine, his saturation is excellent, and he's connected to our ventilator, the Dragger baby lock. He is put on SIMV mode of ventilation. And the settings we start with are a rate of 45, a PIP of 16, PEEP of 5, an I time of 0.35 seconds, oxygen of 25%, and a flow of 10 liters. The measured panel settings on the ventilator show the leak to be 0%. The delivered PIP is the same at what we have set. The PEEP is 5, and the tidal volume which is being delivered is 10 to 12 ml. I think this connection is loose. So in short, the ventilator delivers the same parameters we have set. He's nice and sedated, not taking any spontaneous breaths. There is adequate chest rise, and his vitals are stable. Some questions at this stage. Why did we start on a rate of 45 per minute? We could start with any rate, to be frank. The normal physiological rate is between 30 to 60 per minute. Now, his lungs are fairly normal. He didn't need any respiratory support to start with. So if I would have given him a rate of 60, delivering those pressures, we anticipate that that would cause a washout. Now, it's not good to give a low CO2 for a baby. Ideally, a rate of 30 to 35 would have sufficed. But then because we sedated and paralyzed him for the purpose of surgery, the baby will not be taking any respiratory efforts. So a fairly safe range to start with would be about 40 to 45 per minute. Why is he on SIMV mode of ventilation? Again, because he's sedated and paralyzed, we are reasonably sure he's not going to start spontaneously breathing in a while. Why a PEEP of 16 and a PEEP of 5? For reasonably normal lungs, we give only the bare minimum pressures, and the normal working range of PIP we can start with would be between 12 to 16, and for PEEP 5 to 6. So we can start with this and see how he goes. An I time of 0.35 seconds. The normal ratio of inspiration to expiration in newborn babies would be roughly 1:2, and a comfortable working range for the I time would be between 0.32 to 0.38 seconds. The ideal range of flow in neonatal ventilation would be between 8 to 12 liters per minute, and in cases where you have to deliver very high PIP, it would be essential to give a minimum normal range, sometimes between 12 to 15 liters even. And the fraction of oxygen which is given in newborn babies assumes great relevance for extreme preterms. It is in order to avoid the risks of hyperoxia and resultant end organ damage. But then for this baby, who is near term, it's not of much significance, especially because he's not on any respiratory support. So the FiO2 can be adjusted to maintain a saturation more than 95%. How do I know he's being underventilated or overventilated? That's where the measured panel will show the tidal volume and guide us. Now, I had said that he was getting a tidal volume of 10 ml. For a baby who weighs 1.6 kilos, it comes to just about 6 ml per kilo. And the normal range is between 4 to 6 ml per kilo, so I'm okay with that. Baby is taken up for surgery, the hernia repair is over in about an hour, and he's brought back. During surgery, he was given a bolus of fentanyl. His vitals are stable, but then when he comes back to the unit, he's still sedated. He's responsive to touch, but cold. Temperature is only 35.4 degrees Celsius, which is low. He's put back on the warmer. He's put back in the same settings we started with. We connect the IV fluids back again. Saturation is 100%. And a short while later, we do a capillary blood gas, which shows a pH of 7.18, a PCO2 of 68, PO2 of 48, bicarb of 18.1 with a base deficit of 6.2, and a lactate which is 4.8. There is respiratory acidosis, but then the baby is cold. There is peripheral vasoconstriction. It could explain the elevated lactate. So we decide to increase the rate from 45 to 55, tweak up the PIP a little bit. The tidal volume is 10.5 ml, which is not too high, so I'm okay with increasing the PIP, and we decide to wait and watch. As his temperature normalizes, he slowly pings up. His saturation is fine. We manage to wean the oxygen to 21% in a couple of hours. In the meantime, he passes urine, and a repeat gas shows significant improvement. The pH is normal. The PCO2 is 45 for a capillary gas, that is also okay. Oxygenation is good. Bicarb is 22.8 and his lactate has come down nicely. He is improving. By this time he starts to breathe. He has a rate of 58 to 60 per minute. And the measured panel shows a tidal volume to be 18 to 20 ml. That tells us that he is very active and we could decide on considering extubation. So we start our weaning procedure. We shift him to SIPPV with volume guarantee. We put him on volume guarantee and set the limit at 10 ml. And the SIPPV settings we start are a rate of 40, PIP of 18 by 5, and a night time of 0.32 seconds. He becomes more vigorous. The measured panel shows him to be breathing at a rate of 62 per minute. He is comfortably taking the tidal volume of 10 ml and beyond with a PIP of just 8 to 10 centimeters of water, which is much below the set value. That tells us that he is taking normal breaths. He is ready to be extubated, and at this point, we could very well extubate him. It's also okay to be safe and do a blood gas just to make sure. A blood gas is done. The pH is 7.45, the PCO2 is 38, PO2 is 52, bicarb is 27. Saturation is fine, heart rate is stable, and he is indeed extubated. We do a thorough suctioning prior to extubation. We give him oxygen for a brief while. His breaths were labored to start with, but he resumes normal breathing in 15 minutes' time. And that is a successful extubation. The next case is a 28-week preterm baby boy who's a month old, has reached a corrected gestation of 33 weeks. His birth weight was 920 grams and he presently weighs just over 1.3 kilos. The problem is he has NEC. The X-ray showed pneumatosis intestinalis and gas in the portal vein, and his blood gas showed a severe metabolic acidosis. So how do we manage this case? He's kept NPO. We monitor his abdominal girth. He has a peripheral IV access. We put in central lines. He is sedated and is started on fentanyl infusion for pain relief. We give him blood products as required and we start him on antibiotics. But then shortly after, he develops a cluster of apneas and needs frequent stimulation. What do we do next? We decide to intubate him electively. What is our strategy here? Because it is an elective intubation, we pre-medicate him with atropine, fentanyl and rocuronium. He is intubated with a size 3 ET tube and fixed at about 7.5 centimeters at the lips. Why we choose the size we chose and we fix it at the distance, I'll be explaining in another case scenario. So what ventilator settings and mode would we start him on? He's a case of NEC. It's important to spare a thought and realize that for this baby, the lungs were fine. The problem is in his gut. But then we are ventilating him for the reason that he has recurrent apneas, for the reason that with worsening NEC, his abdominal distension can increase and that can push the diaphragm up and make further breathing difficult. We need to tide over the period of active NEC and wait for the sepsis to resolve. At the same time, he's also on fentanyl infusion. Probably he's not able to take easy breaths. So again, we start him on SIMV mode of ventilation. We start him on a rate of 50, PIP of 18, PEEP of 6, a night time of 0.38 seconds, and an FiO2 of 25%. The tidal volume being delivered despite his lungs being normal, is only 6 ml and the saturation is 98%. So I do not think of weaning the PIP or PEEP just now. We also insert an arterial line because he will need frequent blood gases, he will need invasive BP monitoring. We also give him sodium bicarbonate for the severe metabolic acidosis. Over the course of the day, his abdominal distension increases further. The blood gas done 4 hours later shows improvement. The pH is 7.35, the PCO2 is 32, the PO2 is 88, bicarb is 18.2, and his lactate is still high at 5.8. He is sedated. Therefore, we decide, because the CO2 has come down, to decrease the rate to 45, and the oxygen is also weaned. Serial X-rays are done primarily to rule out perforation. Serial gas is done later on, show the PCO2 to come down further. So the rate is gradually weaned by 5 breaths at a time to about 30 breaths per minute over the next 24 hours. 48 hours after his sickness starts, the abdominal distension starts to come down. Bilious aspirates come down. The CRP decreases. Metabolic parameters improve. Inotropes are weaned and stopped. Fentanyl infusion is also weaned and stopped. And the blood gas shows a pH of 7.42, the PCO2 of 36, PO2 is excellent, bicarb is normal, and the lactate has also come down. As he shows signs of becoming more active, we just opt to give him fentanyl boluses as required. His abdomen is nice and soft. The tidal volume delivered on the ventilator has increased to above 10 ml. We decide to put him on SIPPV plus volume guarantee mode, and we set a volume limit of 8.5 ml for a child who weighs about 1.3 kilos. And the settings we start with are a rate of 40, PIP of 18 by 5, I time of 0.35 seconds, and an FiO2 of 21%. 6 hours later, his saturation is fine. He is breathing at a rate of 55 to 60 per minute. The PIP needed to maintain the set tidal volume is only 13 to 14 centimeters. And his blood gas shows a pH of 7.42, PCO2 of 28, PO2 of 86, normal bicarb and lactate. There is a washout, so the rate is reduced further to 30. He is still breathing comfortably higher than the set rate, and the PIP needed to give the tidal volume has come down even further to 8 to 9 centimeters. So we decide to go ahead with plans to extubate him. The rate is further weaned, serially to 25 and then 20. A repeat blood gas still shows a washout. So we load him with caffeine, and an hour later he's extubated to room air. He's breathing normally in room air. The blood gas 4 hours later is normal. He was NPO for 2 weeks and on TPN, and this baby recovers fully well. So a few points for discussion. Now, this being a case of NEC, and if his lungs were normal, why was he intubated and not put on nasal CPAP? The reason is that if I would have given this baby CPAP, part of the air would have also gone into the bubble, and that would have worsened his NEC. So that was the reason why we decided to ventilate him. And again, that is the reason why we made sure that he would absolutely tolerate extubation, and only then we would extubate him, because otherwise we would have needed to put him back on CPAP after extubation. Now, ventilator settings and mode of ventilation depend on the state of the baby's lung. There are a few cases which need surgery and cases which need management in the NICU, where ventilation is an important part of the management, but then the lungs are normal. Those cases are birth asphyxia, NEC, any gastrointestinal surgical problems like gut atresia, inguinal hernias, orthopedic problems like septic arthritis, a surgery for clubfoot, urological problems like a PUV, bladder extrophy, and so on. And a point I would like to highlight for cases of exomphalos and gastroschisis. It's important to realize that those babies were born with a very small abdominal compartment, as the contents of the abdomen were outside the abdomen to begin with. Post-surgery, when these are put back into the abdomen, there will be elevation of the diaphragm. That is due to the bubble loops and viscera pressing up on the diaphragm. Therefore, in such cases, a slightly higher PEEP than normal would be useful in ensuring adequate lung inflation. So this is the Babylog 8000 ventilator. And what is shown is a baby who is on SIMV plus volume guarantee ventilation, which is the mode is shown on the rightmost part of the screen. And you set the I time, which is the first value, at 0.36 seconds. The third value is the frequency set at 45 breaths per minute. The FiO2 is at the bottom row of the first column at 22. And then you can see the flow on the right side at 13 liters, a PIP of 18, PEEP of 6. Whereas this is the measured panel, which shows that the baby is getting a tidal volume of 5.4 ml. That is the column on the right, second row. There is 0% leak with no spontaneous breaths, which means that the baby is sedated. But the third case is of an extreme preterm baby girl who's born by a normal vaginal delivery at 25 weeks of gestation with a birth weight of 675 grams. Baby has got severe hyaline membrane disease. So she is intubated with a size 2.5 ET tube orally, which is fixed at 5.5 centimeters at the lips. And we start her on neopuff ventilation in the delivery room at settings of PIP of 22 and PEEP of 7 centimeters, and she is shifted to the NICU. So why a size of 2.5 ET tube for this baby? So the appropriate size of ET tube to be used depends on the gestational age and weight of the baby. And at what level is the ET tube to be fixed? The conventional NRP teaching is that the level at which it should be fixed would be adding 6 centimeters to the weight of the baby. Now this is not always true for preterm babies who weigh less than 1000 grams. So for a 23 to 24 weeker, the ideal length at which it could be fixed is 5.5 centimeters, whereas for a 700 to 800 grammer, it could be 6 centimeters. So the rule need not always apply. And we learn this from our experience. Quite often we fix it at 6 centimeters and the X-ray shows the ET tube to be too deep. What is Neopuff? Neopuff is a cheaper alternative to a ventilator, a portable device which delivers positive pressure ventilation. It can be attached to a mobile oxygen source and the pressure will be delivered by an appropriate size mask which is covering the nose and mouth of the baby. Breaths can be delivered according to the NRP teaching in the sequence breathe 2, 3, breathe 2, 3, breathe 2, 3. That will deliver breaths at a rate of 40 to 60 per minute. This would suffice for the purpose of transporting a baby from the OT to the NICU or from the delivery room to the NICU. Ideal pressures to be delivered in neonatal resuscitation. The range of PIP we can start with is between 20 to 24 centimeters and an ideal PEEP in the range of 5 to 8 centimeters. The saturation, the heart rate, the color of the baby and chest rise will guide you whether you need to increase it or decrease it. And the ideal oxygen to be delivered. For term babies we can start with 21%. For preterm babies we can start with 30% and can bring it down as needed. So in the NICU, this baby is on SIMD mode of ventilation. Settings are a rate of 50, PIP of 22, PEEP of 6, I time of 0.38 seconds and an FiO2 of 30%. There is good chest rise, bilateral equal air entry is confirmed. The saturation is 93%, not very high. There is no ET tube leak and we see that the delivered tidal volume is low. So why a rate of 50 here? The normal range is 30 to 60, we could start with any. But then, if I give too little a rate for such a baby who's got hyaline membrane disease, that can worsen the respiratory acidosis. That's why I opted for 50. What is the ideal range of PIP for RD as HMD? The range is 18 to 24. Very often we would need the upper limit of the range to start with. The tidal volume, saturation and FiO2 will guide you. And it is a common observation that the PIP requirement decreases after giving surfactant. That is because of improvement in the lung compliance. The ideal range of PEEP would be between 5 to 7 centimeters, but then too high a PEEP can cause CO2 retention. The X-ray was taken, an air bronchogram and whiteout is seen, which is a clear-cut case of HMD, and we give a surfactant. And the first blood gas done shows a pH of 7.18 and a PCO2 of 64 and a metabolic acidosis. So there is a combined acidosis. Just A few points about neonatal X-ray, which is an important adjuvant that helps in decision making in ventilation. The ideal lung volume for newborn babies is between 6 to 8 lung spaces. The ideal position at which the ET tube should be fixed is just above the carina, which would be T3 to T4 level. The OGT in proper position helps to decompress the stomach. Quite often that will help in ventilation. Shortly after surfactant, the saturation improves to more than 95%. The FiO2 is gradually weaned to 21%. A repeat blood gas after 3 hours shows the pH to be 7.32 and the PCO2 to be 48, and the oxygenation is excellent. The tidal volume is improved to more than 3.8 ml. We don't fiddle with the settings just now, we decide to observe. Why do levels of oxygen and CO2 matter in preterm babies? That was touched upon the previous presentation. Hyperoxia causes free radical damage to vital organs, especially the brain and eyes, which is why we are very fussy about weaning the oxygen. Hypercarbia and hypocarbia both can damage the brain, can cause IVH as well as periventricular leukomalacia, which are forerunners of cerebral palsy. Another 3 hours later, there is a washout. The pH is 7.44 and the PCO2 is 30. Saturation is 98%, is pink and active. The delivered tidal volume is well over 4 ml. So we reduce the rate and we reduce the PIP because the oxygenation is also good despite the FiO2 being 21%. Serial blood gases are done like this for the first 2 to 3 days. We managed to bring down the rate to 25 and the PIP to 16. The PEEP is still kept at 6. On the third day, the blood gas shows a pH of 7.38. The PCO2 is 37. Oxygenation is good. Metabolic parameters are good. Tidal volume is good. And the baby is breathing at a rate of 68 per minute. Chest X-ray is okay. At this point, we decide to change the mode to SIPPV plus volume guarantee. The tidal volume is set at 4 ml, corresponds to 6 to 7 ml per kilo. We put up a backup rate of 45, a PIP of 18, a PEEP of 6, an eye time of 0.32 to start with.
Dr. Madhu, we are exceeding it.
Yeah, I'm sorry, I'll try to quickly finish. I also wanted to touch upon high frequency ventilation. Is that okay with you?
We need to.
I did seek their consent before presentation. I'll try to be fast. So serial gases are repeated. And 8 hours later, the blood gas is absolutely fine. Saturation is okay, and the delivered PIP has come down to 12 to 14 per minute, 12 to 14 centimeters, and therefore the backup rate is decreased further. By day 9 or 10, while on SIPPV and volume guarantee, on fairly minimal settings, the blood gas in the 4th line is absolutely fine, and that tells us that we could extubate her. So she is extubated after reloading with caffeine citrate. By week 29, she is also on nasal CPAP, and by week 30, she is off all forms of respiratory support and breathing in room air. So this was to highlight SIPPV ventilation, and you can see the set panels and the measure panel, which shows that the tidal volume is 6.9, and the baby is taking 53 breaths per minute, which is more than the set rate. The last case scenario is to highlight high frequency ventilation. So we have a term 38-weeker gestation baby whose antenatal scans had shown polyhydramnios, and he weighed 2.8 kilos at birth. He was born with respiratory distress, confirmed to have esophageal atresia at birth. So he's intubated and shifted to the NICU. The chest X-ray taken shows esophageal atresia with a tracheoesophageal fistula. He started an SIME ventilation here. The rate is put at 60 because of the severe respiratory distress. We start with a slightly higher PIP than normal, which is 20, and a PEEP of 6, and the FiO2 of 30%. His saturation is still only 90%. Heart rate is 138 per minute, so the oxygen is increased to 40%. The blood gas done at 1 hour of age shows a pH of 7.24 and a PCO2 of 68, so there is a respiratory acidosis. The delivered tidal volume is 8.8 ml. There is no leak. He's kept NPO, started in IV fluids. The PIP is increased to 22. The surgeon reviews him. Echo ultrasound scans are done to rule out further anomalies. And a repeat gas after 3 hours shows a pH of 7.3, PCO2 of 52. The CO2 has come down, but not very much. Saturation is fine. we wean the oxygen and the tidal volume delivery improves to 10.8 ml. There are no other anomalies. Anesthesia reviews him, he is posted for surgery the next day, and the settings at which he is taken for surgery are a rate of 55, a PIP of 22, PEEP of 6, and an FiO2 of 25%, and prior to surgery his gas was fine. Following surgery, where the repair of the fistula and the esophageal atresia was done, he is sedated and paralyzed, having received multiple doses of fentanyl and rocuron. He is on FiO2 100%, saturating at 93%, and is brought to the NICU by bagging. Shifted to the warmer, started in the same settings at which we left him. He is mottled, he is hypothermic, capillary refill time is prolonged, and his blood gas on arrival, pH of 7.08 and a CO2 of 78, which shows a respiratory acidosis. But then he was hypothermic. We see whether he improves with rewarming. We confirm that the ET tube is still in place. There is no leak. The tidal volume is slightly on the lower side. An X-ray is taken, the tube is in position, but the lungs are under-ventilated. He is on fentanyl and rocuronium infusions. He is catheterized. We do a blood gas after 1 to 2 hours. The blood gas after 1 to 2 hours actually shows worsening. The pH is 6.98, the PCO2 has gone up to 92, oxygenation is not very impressive, and he has hypotension. We start him on inotropes, and we decide to change to high-frequency ventilation. So why is he on high-frequency ventilation? Because of worsening respiratory acidosis. How long does he need that for? Till as long as he normalizes and the settings are minimal. What special precautions do we need? Well, in high frequency, we will need more blood gases frequently, and an arterial line will come in handy. The basics of high frequency, the idea is to improve both ventilation and oxygenation. And the three important settings here would be frequency, delta P, and the mean airway pressure. Frequency and delta P helps in CO2 removal or ventilation. The MAP and FiO2 adjust oxygenation. The ventilators we use here which deliver it are the Sensor Medics SLE 5000 and the Drager Babylog WIN 500. So in order to improve oxygenation, we can increase the MAP and increase the FiO2. In order to decrease CO2, the settings are increasing the delta P or paradoxically decreasing the frequency. So how do we start? The conventional default settings we could start with are a frequency of 10 Hz. The MAP would be set at 2 values greater than whatever was the MAP on SIMV, and a delta P value just enough to ensure vibration of the chest wall. So therefore the settings we start with are at 10 Hz, delta P of 22, a MAP of 12, and an FiO2 of 60%. Chest wall is vibrating well, his vitals are stable. We repeat the gas after 2 hours. So this is the SLE 5000, this is on conventional ventilation, and this is on the high frequency ventilation with the frequency, MAP and delta P displayed in the panel below. So the ABG after 2 hours shows an improvement. The pH is 7.26, PCO2 is 64, oxygenation is excellent. So we keep the settings unchanged other than weaning the oxygen, and we repeat the gas after 3 to 4 hours. And the repeat gas also is good. 7.32 is the pH, the PCO2 is 38. So now that the CO2 has come down, the delta P is reduced. And ABG 6 hours later is also fine. The delta P is reduced further to 18. With improvement in oxygenation, the MAP is reduced to 11. FiO2 is weaned as required. And an ABG 4 hours later still shows a washout. At this point, we decide to increase the frequency from 10 Hz to 11 Hz. Now this is where I will make it a cat and mouse game. I just present a slightly alternate scenario where, after starting him on HFOV, rather than an improvement, a repeat gas actually shows that he has worsened. The pH is 7.08 and the PCO2 is 82. So at this point, what we do is, we take an X-ray just to make sure that there are no other factors which worsen the ventilation. And our fears turn out to be true because this baby has got a collapse in the right upper lung and his ET tube is also a bit low. So we make the necessary adjustments, we give him physio, the ET tube is pulled back, and the next gas actually shows that there is an improvement. So how do we make these adjustments in delta P? Delta P is adjusted, the increments or decrements would be 2 at a time. How do we adjust frequency? Again, increments or decrements are made 1 at a time. And MAP is also increased or decreased by a value of 1 at a time. What is too high a MAP for a newborn baby? It actually depends on the size of the baby and the severity of the lung disease. Generally, any MAP more than 16 is very high. What is too high a delta P for a baby? It also varies from baby to baby. Seldom do we need a delta P more than 30 in our practice. What is too low a frequency? Any value lower than 7 is too low. Clues to a high MAP in the X-ray would be looking for flattening of the diaphragm and also looking for a decrease in the mean blood pressure. So after high frequency ventilation on settings of 11 Hz, delta P of 18, MAP of 11 and FiO2 of 30%, the gas is still fine. We managed to bring down the MAP to 9 and frequency is brought to 12 Hz. So the decision is when do we put him back on SIMV. At fairly minimal settings, frequency of 12 Hz, if we have a delta P less than 20 and a MAP less than 10, we can very well put him back on SIMV, which is what we do. He is put on SIMV and a gas is repeated after 3 to 4 hours, which is also fine. Over the next 3 to 4 days, he is then put on SIP PV plus volume guarantee. Settings are further weaned. By the 10th post-operative day, he is extubated to high-flow nasal cannula, and by the 13th post-operative day, he is breathing in room air. So generally, indications for high frequency, you could use it for any baby. It is used as a rescue option for any case of severe respiratory acidosis. It can be used in HMD, it can be used for pneumothorax, it is used in cases of pulmonary hypoplasia, it's used for pulmonary hypertension, and for babies with congenital diaphragmatic hernia, along with inhaled nitric oxide. So, I don't know whether the message was conveyed. Was it clear enough, or was it as clear as mud? I have no idea. But then, that was the cat and mouse game, and that finishes my presentation. I've tried to keep it as simple as possible, and I finish by expressing my gratitude again for this opportunity to speak. Thank you.
Yeah, thank you so much for covering this vast topic. It's really challenging to adjust settings in these patients and keeps you on toes all the time.